Welcome back to Long COVID Doctor, an educational series for sufferers of long COVID. This is the second part on dysautonomia and long COVID. In the first part, I talked about the symptoms, the diagnosis, and the investigations. In this part, part 2, I'll talk about the treatments, management, and outcomes. References, links, and resources are in the show notes below. As I said before, any advice, diagnoses, treatments that I mention should only be considered after discussion with your own GP or qualified health professional. So here we go, part 2 of dysautonomia and long COVID. So, what are the specific treatments for long COVID dysautonomia? As I explained in part 1, there are so many causes for dysautonomia. It's impossible to be certain what the main cause is. It may be something to do with the excess inflammation or autoimmunity or microclots or viral invasion, some or all of those to varying degrees. And so obviously one treatment or cure is not a realistic option. And so what it comes down to is finding ways to manage the symptoms of dysautonomia. And what are they? And how do we tackle them? So let's work through those symptoms. So the gut symptoms, colicky, pains, in the stomach, in the abdomen, bowel frequency, bloating, the sort of IBS, irritable bowel syndrome type symptoms. Antispasmodics are recommended for those type of symptoms. So mebeverine, otherwise known as Colofac, or peppermint oil, Colpomin, or antidiarrheal medications such as loperamide, Imodium. So those dysautonomic gut symptoms can be controlled with those medications. And then there's nausea due to dysautonomia. That can be controlled with cyclizine or ondansetron. Dizziness and vertigo, head spinning, can be helped considerably with prochlorperazine, otherwise known as Stemetil. Headaches due to dysautonomia can be helped with amitriptyline, or topiramate, or candesartan. Neuropathic pain due to nerve pathways, nerve pain, can be helped with amitriptyline also, but there's also another drug called duloxetine, which is frequently used for neuropathic pain. And then remember I was talking about disruption of the thermoregulatory centre that brings about flushing and sweating. So it's not unreasonable to trial HRT. Another byproduct or side effect of dysautonomia is anxiety, worry, stress, depression. As a result of reduced production, increased turnover or reduced storage of serotonin, as well as the limbic system disturbance. So for anxiety, depression, with those physical reasons behind them, the use of an SSRI is very helpful. So citalopram is probably the one that's most widely prescribed. More on this on my talk on anxiety and depression in long COVID. And then finally there's sleep disturbance. Again, I've talked about how the pineal gland that secretes melatonin can be affected by long COVID with dysautonomia. So it's important to try and tackle sleep disturbance, and you can either use an old-fashioned antihistamine, Piriton, or amitriptyline for its sleep-enhancing effects, or melatonin itself, which is a supplement. Again, More on this on my talk on sleep disturbance in long COVID. So those are the ways we can treat the commonest symptoms of dysautonomia. But as I said, this isn't treating the underlying cause. They are only symptomatic treatments. Focusing now on the more specific features of dysautonomia. Firstly, POTS, and then secondly, MCAS, or mast cell activation. You'll remember that there was this crossover of symptoms between dysautonomia and mast cell activation. So firstly, POTS. Let's talk about that first of all. So POTS, positional orthostatic tachycardia syndrome. I've said that a number of times now. The non-pharmacological management of POTS. We start that with the non-pharmacological. So adequate fluid intake, sort of 2 to 3 litres per day. Salt, 1 level teaspoon of salt, 6 grams of salt a day. If that's not tolerated, you can get slow release sodium tablets. Dosage 2 tablets 3 times a day for 30 days maximum. But obviously care with patients who might have chronic kidney disease and children and patients with raised blood pressure. And then leg compression, so class 2 long socks or preferably thigh length stockings to push the blood up into the circuit, back from the legs, back up into the circulation. Other measures such as eat small meals. Why? So there's less blood in the gut bloodstream, the bloodstream that serves the gastrointestinal tract. Alcohol in moderation. Why? Because, as we all know, alcohol is a vasodilator. It widens blood vessels, and a widened blood vessel will drop blood pressure. The heart then compensates by accelerating, so you get your palpitations that way. So moderation of alcohol, but also moderation of caffeine intake. So just not excessive coffee drinking, please, because caffeine is a cardiac stimulator. Note also that obviously there's caffeine in tea, but half the dose. So that's the sort of non-pharmacological, non-drug ways to manage POTS. What about the drug ways to manage POTS, the pharmacological ways? Well, the first line treatment is bisoprolol, which is a beta blocker. Some advocate propranolol. It's not, in my view, not as good because it's less cardioselective, and so it's more likely to have side effects and sort of heavy legs, and can lead to sort of bronchospasm or asthma, triggering asthma. Basically start low, go slow, start with 1.25 milligrams once daily, and then increase it slowly according to the response. Basically, you might get away with a low dose, 1.25 milligrams, but most people need probably 2.5 once or twice a day as their dose for a beta blocker, bisoprolol, to control the palpitations and hence control POTS. If bisoprolol isn't tolerated or it's contraindicated or it's ineffective after 4 to 6 weeks trial, then the next drug for POTS is ivabradine, and 2.5 to 5 milligrams twice a day. This is a selective sinus node inhibitor. It slows the heart without reducing the blood pressure. Note that it is off-label. It's not licensed for the treatment of POTS. So I think most GPs seek the advice of cardiology rather than initiating it itself. So that's the first specific dysautonomic condition that we need to be treating. That's the POTS. Okay. Now on to the other specific dysautonomic condition, the MCAS, or mast cell activation. Just as a reminder, MCAS is part of the excessive inflammatory response in long COVID, in which mast cells release their inflammatory chemicals, especially histamine. And so to deal with this, we need to prevent the mast cells releasing those chemicals from degranulating. We call it degranulating when they release their chemicals. And the medicines to do this, to prevent that degranulation, are the H1 and H2 blockers in combination. H1 blockers, the antihistamines, cetirizine, loratadine, and fexofenadine are the ones that we use. They're second generation antihistamines, non-sedating antihistamines. Licensed for once a day treatment. If there's no response or only very mild response, it's reasonable to double the dose. So take one tablet twice a day, but after about a week. This is off-label again. This isn't, they're not licensed to be used in mast cell activation in the long COVID setting. And so medical advice and supervision is needed from your GP, like I said before, if increasing doses are being considered. Continue the H1, the antihistamine, for 3 months and then stop it and see whether the symptoms return. If they do, obviously restart the tablet. If they don't return, then happy days. Your mast cell activation is quietening down and has settled. The other drug which is used in tandem with the H1 blocker are the H2 blockers, the anti-acid drug. Okay, the one used is famotidine, 20 milligrams once a day initially, and like my advice on increasing the doses with the antihistamine, increase to twice a day if tolerated after a week. But again, with medical advice and supervision. As I said, this is just a quick reminder of what MCAS is, mast cell activation. So if you want to know more, obviously check out my talk on MCAS. So what else can we do to help the recovery from dysautonomia and long COVID? It's so important. And I always say this, is to take into account the whole person, the holistic view. We need to think about nutrition, sleep, and mind-body strategies. So nutrition, I've talked about the mixed balanced diet, the Mediterranean diet before, supplemented by fish oils and vitamin D. Sleep support, I've touched on that earlier. And mind-body strategies, meditative mindfulness, living in the moment, as they say. Yoga for focus, breath work, and musculoskeletal conditioning. Both of these strategies have benefits backed up by lots of research studies, so worth a try. And so, besides all that advice and recommendations, there are a few resources that are helpful, specifically for POTS, but also for long COVID in general. I've listed them in the show notes below. And so there we are. The treatments and management of dysautonomia, both specifically and generally. And finally, what about the expected outcomes? I said I'd talk about that, didn't I? The expected outcomes and the time course. These are the questions that patients frequently ask, and understandably. What are the outcomes? And how long will it take to get better? The answer is, well, it's not easy, it's unpredictable, and made more difficult with not being able to treat the underlying cause of their long COVID dysautonomia. And so it's a matter of waiting for natural healing to happen. The processes that take place to bring that recovery, and there are many of them, are sort of nerve fiber repair and regrowth. So those nerve pathways reconnect, the process of neuroplasticity. The immune system will normalize sooner or later. It will quieten down. And so therefore the inflammatory state will settle down. Mast cells will also settle down and stop being activated. So therefore less inflammatory mediators circulating and kicking off immune response. And what goes hand in hand with that is, with less inflammation, there's less blood clot, mini microthrombi, microclot formation. And so those blood vessels that have been clotted off with the mini clots, the microclots, will eventually clear by natural process of what's known as recanalization. But also new blood vessels are created around blockages where there's a blood clot, neovascularization it's called. And then there's, with everything else quietening down, there's sort of a rebalancing of the autonomic nervous system pathways that happens, so that all those areas of the autonomic nervous system, the sympathetic, the parasympathetic, the enteric, the limbic system, HPA, all begin to settle down and, if you like, go back into sync and rebalance. And what about the time course? Again, the other question our patients ask us. Well, I'm afraid it's impossible to predict. Previously, we thought that long COVID lasted like 12, 18 months and then it was all over and they were back to normal. But, as the time's gone by, and, this is now like 3.5 years on now, things are very different to what we originally thought. And, basically there are still patients coming through, new cases coming through with long COVID. So, in a word, the time course, it's unpredictable. But meanwhile, we must hold on to the fact that improvement will occur. Okay, this is what we're seeing in our clinics. It's slow, but it does occur. People do go back to normal life. And that occurs with natural recovery from long COVID and the rebalancing of those body systems that I've talked about, the inflammatory system, the immune system, the endocrine glandular system, and the nervous system, along with the natural tissue and cellular repair. But above all, we need to give it time for all those natural healing processes to work. We need acceptance to accept it. We've been unlucky. You've got long COVID. We need to accept it and don't fight it. We need to give it time. So there we are. That concludes the part 2 of my talk on dysautonomia and long COVID, following on from the first part earlier. I hope you found both of them helpful. As I mentioned at the start, any advice, diagnoses, treatments that I mention should only be considered after discussion with your own GP or qualified health professional. So, in the meantime, I wish you well. I wish you well in your long COVID recovery. Cheerio.